Here we go with some of that medical information you need to know. And the doctor is very, very qualified to do these shows. We run them 5 days a week on our resource hour. We also do a 1 hour show on News 96.5 in Orlando. I want you to write down two things: suffernomore.com, suffernomore.com, and stagesoflifevitamins.com. All right, doctor, pain medication and addiction. Now, I understand that you had one of the first, if not the first, pain clinic in the United States.
It was the first office-based center. Okay, they were all university-based up until that point. I was told I was foolish to go ahead and try it because, after all, it's a university type of a specialty.
Oh.
So I opened one up in a small town, became the largest in the world. It didn't take long for that to occur. So I have some basis for this opinion, and it's almost 40 years worth of experience. The story with opiates, the story with pain medications, the story with addiction is it's not one story. Okay? Addicts become addicted and patients get into pain. Now, pain is the most common of all complaints bringing anybody to a doctor's office, followed only by bleeding. Okay? So if a guy is going to go to the doctor's office, okay, it's going to be for pain or bleeding or something's happening to his genitalia. Those are the three things that bring a man to a doctor's office. Women, preventive maintenance works just fine, but generally it's pain or bleeding. Well, that being said, okay, what is it about pain medications that's causing such a great bit of attention in the media right now? And it has a little something to do with governmental intervention that went wrong. Go figure. Unintended consequences often follow governmental action. Now, for the longest time, okay, we looked at pain as being something that you would see with things like cancer, orthopedic injury, neurological injury, just everyday degradations and disease states. It's associated with pain. Pain is an integral part of our experience as human beings. And we take medications to treat pain on a daily basis, whether it's an opiate, whether it's alcohol, whether it's an antihistamine, whether it's a sleeping pill, antidepressant, or a diabetes medication, because one of the first and most humbling experiences I've ever had as a doctor was early on. And a patient came in with Guillain-Barré syndrome. Her ear moved, and it was driving her nuts. So I asked her why she came into the pain center to get, she said, to fix this. And, she said, well, I was told that you could figure things out, you're the last resort. And I figured, okay, I'll figure it out, but what makes this hurt? And she looked at me, and she goes, Doc, there are a lot of ways to hurt. And it occurred to me, okay, that I really wasn't thinking properly. You can have heartache. Okay, what does that mean? It means that you're depressed. You can have a headache, which is something that anybody can measure, but you can feel. You can see things, lacerations, trauma, crushes, and so on and so forth. There are different ways to experience pain, and that's just the way that it goes. But the medications that we use reflect the disease process itself. So if you have dental pain, okay, the single most effective pain medication you can take is an anti-inflammatory, something similar to naproxen. Okay, if you break a bone, the simple, most effective medication is going to be an anti-inflammatory like naproxen. Why? It has to do with the pathways that are disrupted or triggered by the orthopedic event, or by the dental effect, or by the traumatic event. The opiates are used for something very, very different. What other sorts of things could cause pain? Well, if you've ever had nerve pain, diabetics are easily treated, all things considered, using anticonvulsants. Now, for years I used Dilantin. It's no longer used quite as much as it once was. It's probably become too inexpensive. Gabapentin followed that. Okay, when it became inexpensive, people start to use it less. But there are other anticonvulsants that, when they're used in combination, treat diabetic polyneuropathy, burning pain in the feet and elsewhere, when the opiates will not. So the confusion is rather interesting from my perspective. Is it the pain medication that's causing the problem, or is it the pain selection? Is it the expertise of the individual that's doing the choice? Now, what do you think the problem is here? If you can take somebody with no training whatsoever, but all they have is an MD after their name and a license, which, by the way, is the state's intervention, these individuals can, in fact, write whatever opiate prescriptions they want for whatever length of time. Therein lies the problem. Now, they've recently changed that here in the state of Florida, but they haven't changed it uniformly elsewhere. When will these changes be put into effect? The 1st of July. The problem isn't the opiate. The problem is the patient. Now, who overdoses on these medications? Okay, do you think that the opiate epidemic, the prescription items, are going to prevent anybody from overdosing on cocaine? Do you think it's going to prevent anybody from overdosing on heroin or IV Dilaudid or IV? It's not going to change anything. If you go ahead and you snort your medications, for those of you that are naive to this sort of thing, it means crush it, stick it on a piece of paper or on the table, and inhale it. That's not really the instruction on the bottle that says take 1 tablet every 3 to 4 hours as necessary for pain. So in the treatment of pain, if you are in fact experiencing pain, okay, the opiates can be a godsend. On the other hand, if you're taking them and you figure, well, if I'm going to take this, I should quote-unquote feel something, you are likely to become addicted. So again, 60-some thousand patients into this over the past close to 40 years now. When somebody comes in and they tell me, gee, I don't feel the medication like I used to, the hairs on the back of my neck go up, and I start to feel this is the individual that has a very different problem than the backache that they're trying to describe to me. Because a real, honest, forthright individual doesn't want to feel anything from the opiate. They want to have pain relief. Now, addiction and habituation are very, very different.
Well, I had a question. You spoke of the Florida law.
Yes.
And earlier in the conversation, you spoke of unexpected consequences. I mean, this is a bomb waiting to go off.
Oh, you betcha. Well, you remember when we had the state's attorney on here, and I was talking to him about Dilaudid becoming the next epidemic.
Yes.
The next problem. Why? Because when you take oxycodone off the market, they're going to look for the next best thing, which in my experience is going to be Dilaudid. He didn't even really understand what that was about. What are we seeing right now? Dilaudid being the next great thing. This is just the way that these things go. So the epidemic was actually manufactured by the state and perpetuated by the state because they did not intervene in order to control things. But there's still problems out there, one of which is the non-physician ownership of medical practices. As long as that happens, you are going to continue to have problems. Now, you cannot own a dental office unless you're a dentist. You can't own a law practice unless you're a lawyer. You can't even own a surveying office unless you're a surveyor. But the guy with a construction company can open up a pain center, a medical practice. This is the oddest state in the world for that, and this is where these things occur. Why? Because if the doctor does something wrong in one of those centers, they arrest the doc, but they don't arrest the center. Okay, so what do? They put the next miscreant doc with a history in there until they generate a bunch of money, and then they get hauled off to jail. So the problems still exist. The fact that the pharmacies are dialing down what they're permitting to be dispensed is a great idea. I'm all for it. But they're going to drop their guard. It gets back to this vigilance thing, this necessary observational skill that a lot of people don't have. They think, well, it feels good to do what we just did. We're going to do something because it feels good. When in fact, it doesn't really matter how it feels. You need to look at the effect. If you do not fix this non-physician ownership of doctors' offices, it's going to continue to be a problem. A lot of folks are going to die, and they're going to continue to blame the docs that are doing it right, and more so, they're going to blame the patients, which they shouldn't be doing.
Well, what's on my mind is, like, I suffer from some maladies, and I need pain medication more than 3 days.
Yes. Yeah, there you go. Okay, so happily I've got the board certifications that permit me to do that.
Good.
Okay, so that is not going to be an issue for you or my other patients. It's not going to be a problem. But the family docs, 3 to 7 days. 3 days if it's a routine type of a deal. 7 days if they want to do the paperwork that goes with it. Guess who doesn't want to be doing any more paperwork? The doc. They're already buried to their neck, and that's the way these things go. So what's the difference between addiction and habituation? And this is a very important bit of data that you need to understand, because everybody has an opinion on this. Whether they know anything or not, whether they have any education or not, whether they have any experience or not, they still have all kinds of opinions. One person, one opinion, sometimes one person, multiple opinions, but everybody has at least one. Well, here's the difference. When you're habituated to something, the body will change physiologically to adapt to it, whether it's tachyphylaxis, that's the body's ability to balance out as a result. In other words, you may need more of something in order to have a net effect. Antihistamines, you'll see it with antidepressants in particular. You may see it with certain antibiotics. That's the way these things go, but it's certainly not an addiction. So you need more antidepressants. What do? You give them more. Okay? It's okay. What happens with blood pressure? You go ahead and start people on blood pressure medications. They take it. The blood pressure comes down. All right? Not a problem. If you give them more, you give them more. But with pain work, okay, if you're actually properly treating the pain, the dosages do not go up. I have patients that have been on the same medication, same dosage for over 20 years. Okay? You have to treat the underlying issue. But if you're chasing somebody with an addiction, well, doc, I've been on this stuff for a year now. I need an increase. Well, we don't give cost of living increases to pain medications. That's what got these people into trouble to begin with, and that's where the problem has to stop.
SufferNoMore.com, SufferNoMore.com, and StagesOfLifeVitamins.com, StagesOfLifeVitamins.com, and we want to thank the doctor for his expertise.